Oh, all right. Good morning, everyone. Welcome to Healing Starts Here. I'm Sarah Brown. And today we have two wonderful speakers. We have Jody Futornik. Sorry, I don't think I've ever had to pronounce her last name. Who is the co-chair for the ethics committee for the entire Swedish system, which includes the ethics consult team. And then we also have Rebecca Cedargreen, who's a member of the ethics committee. Both are chaplains at Cherry Hill, and they're going to be talking to us today about the moral distress of end of life, the decisions you would make versus what is actually being done. So I'll go ahead and pass it off to Jody, and I hope you enjoyed today's presentation.
Thank you. So we're going to save questions for a little bit later. I'm going to do a presentation here, go through it fairly quickly, and then I'm going to turn it over to my colleague, Rebecca, who's going to go a little more deeply into, now that we know what we're experiencing, how do we deal with it? And at that point, we're going to open it up to discussion. So the topic that we're covering is, what is moral distress? And specifically, how does it apply to cases where you might make different decisions than what's actually being done? Next slide. So what is moral distress? Moral distress is when you feel that you know the right thing to do and you're not able to do it. Maybe because it's outside of your scope of practice to make certain decisions. Maybe because of your chain of command, you're just not able to walk outside that box, and yet you feel in your heart of hearts that what you're seeing is not ethically or morally right. And you feel unable to act in accordance with your own values or obligations. This patient is feeling pain. I want to be able to give them more pain medication, and I can't. That kind of thing. I don't think that we should continue with this advanced intervention. Rebecca and I are over at Cherry Hill, so we deal mostly with cardiac interventions, but it can be a cardiac intervention, it can be chemotherapy, it can be a huge range of treatments. And I just don't feel like this patient is getting better. I don't think they really want it. And yet there are people who are saying we need to keep going. And what happens when you find yourself in that space is that your professional and personal integrity feel compromised. Am I really who I think I am? Am I really the nurse or the chaplain that I set out to be? You can feel complicit with a moral wrong. And how often we've heard nurses say to us, I just can't keep doing this to this patient, and yet that's the orders that I have. And you can feel powerless. Next slide. What causes moral distress? Well, here are some examples. Having to make difficult decisions about life or death triage or resource allocation. We saw a fair amount of that, not so much in this part of the country, but certainly in other parts of the country where in the moment decisions had to be made for rationing resources. Who gets this next ventilator? Who gets the ICU bed? Because there's just more demand than supply. You can walk away from a situation believing that if they had just been allowed that resource, you would have been able to save their life, but you were unable to do so. Sometimes witnessing what you perceive to be unjustifiable or unfair acts or policies. So even though there's a very tight structure for making decisions about allocation of scarce resources, when you're not necessarily privy to it, decisions can seem arbitrary or capricious. And if you're not inside of that process, it can feel like it's just unfair. You can feel a sense of betrayal, like they say, this isn't what I signed up for. And why aren't these people listening to me when I have such a clear vision? You can feel survivor's guilt. And again, this applies more to times of pandemic when, how come I didn't get sick? I mean, thank God I didn't get sick. My family didn't get sick, but all these people, my neighbors, my kids' friends, I mean, how did it not come home to me? The other thing that we found a lot of during the pandemic was people who were afraid of infecting people with whom they came in contact, right? So, the stories about person who goes home and before they even walk into the house in the mudroom, they take off their scrubs and then throw them into the washing machine to make sure to get all of the infection out. By the way, I have to say that I have a partner here in my presentation. Her name is Kitty. She has 4 paws and whiskers, and she purrs, and she sometimes likes to insert herself into the camera. So, I'm just going to keep going. But if you notice a tail or a whisker or something, that's my kitty. Okay, next slide. And then coming out of moral distress, what is moral residue? Moral residue is when these events happen so often that they never quite go away. They keep building on themselves. And this is an aspect of moral distress that's integrated into your thoughts and views of yourself. You can end up feeling like, I'm just not up to this. I can't do what I signed up to do. And, and it keeps happening again and again, these same kinds of distressing situations. And that can be really damaging to yourself and your career. When your whole self-image changes from that of a healer or provider of care to a person who's less effective, that can be really potentially damaging. And again, especially when morally distressing episodes repeat over time, over and over again. And then along with that, next slide, we talk about the crescendo effect. And that goes along with this moral residue. The moral residue is what stays with you, right, and never quite goes away. The moral crescendo is the snowball that keeps rolling bigger and bigger. This is real and it's dangerous. It can linger for months and years. This is the kind of thing that leads to what we call burnout, because you kind of feel like your inner resources are depleted. It can lead to emotional exhaustion. I just can't keep doing this anymore. Anytime when we talk about advanced directives, we ask patients to weigh the burdens versus the benefits of treatment, right? Would you want this treatment if the burdens outweigh the benefits? So I use those words of burdens and benefits when talking about these kind of work situations, because when you get to the point where it feels like the burdens of doing your work outweigh the benefits that you're getting, that can really lead to burnout type of behavior. Unrealistic expectations. If I just keep doing this or I just keep doing that, it will get better. Closed-mindedness. This is especially important because how often do we fall into judgments? You have a conference, a care conference, and the doctor is talking here, and the family is talking here, and the doctor is saying, look, there's really nothing more that we can offer. And then, unfortunately, sometimes they'll come with, but we could try, and families will often glom onto that, but we could try. And sometimes as the nurse or the chaplain or someone else in that situation, you start making judgments. This family is impossible. They're unrealistic. They don't get it. Well, maybe they do get it, and that's just the quality of life that their loved one would have wanted, or they believe it to be so. The closed-mindedness can lead to some real dangerous thinking and ceasing to regard our patients, their families, even the physicians, the providers we work with, ceasing to see them with positive regard. And that is dangerous, because at that point, the therapeutic rapport takes a beating. It can also lead to boundary blurring between the suffering of the patient and one's own. The most dangerous thing that I can do as a provider is to put myself in the position of the patient. What would I want? Because I'm not that person. Or to put myself in the position of the family member. I'm not that family member. I mean, I can be there to empathize with them. I can be there to guide them. But once I become that person, and what I perceive to be an indignity done to that person is being done to me, I've lost all my ability to be objective and professional. And that's a worry when the moral distress continues to creep up. Next slide. So let's look at a case study. This happens to not be a COVID study. This is a composite study based on a couple of our past ethics cases. And by the way, I just want to insert something here because you're going to hear a little bit more about our ethics consult team. And just to be very clear up front, the ethics consult team is available to hear your concerns, to provide an objective set of eyes, to encourage you to weigh values against each other. We are not there to make decisions. We are not the ethics police that comes in to fix a situation. I think that sometimes when a situation feels truly desperate, you want the cavalry to come in and fix it, and that's not who we are. And sometimes we disappoint because the expectations are that we're going to say no or yes. And that's not what we do. What we do is we say, this is our opinion based on what we've seen, and then we run it through the criteria. So let's look at a case study of a man who's 70 years old. He has diabetes, end-stage renal disease. He's on hemodialysis, and now he's in sepsis for a post-below-knee amputation. He's critically ill with a high probability that he will likely expire in the next few hours or days, despite maximal medical management. The ICU team has had several family meetings to discuss goals of care with the patient's DPOAs, son and daughter, and there's been conflict between the DPOAs regarding the direction of care. The daughter wants a full code and ongoing aggressive care. The son would like to transition to hospice and make his father DNR. Both of them, when they talk, they speak passionately, and it sounds like each of them had spoken to dad before he got sick, and they knew in their heart of hearts what dad would want right now. Daughter says, oh, come on, bro, you know that dad was always a fighter. And son says, look, sis, we need to let him be at peace. He wouldn't want to live with his quality of life. Another parenthetical addition, by the way, note to self, it really is not a good idea to appoint multiple DPOAs for just this reason. It's really better to have one person who you trust who will be able to stand up to other people who might object and carry out your wishes. Okay, end of digression. It is the opinion of multiple independent providers, different specialties. Pulmonologist has spoken, the hospitalist, the intensivist, the nephrologist. They've all weighed in, and they believe that ongoing resuscitation efforts are futile or non-beneficial is the better word, actually, or non-beneficial. The burdens will well outweigh the benefits. In particular, CPR and advanced cardiac life support in the context of a code blue would be absolutely harmful to him and provide no medical benefit. Then you add into the equation that the patient's last documented pulse, which was from last year, signed by the patient, requested for do not attempt resuscitation status. And this can be tricky because, again, you've got multiple DPOAs, and it's a high ceiling, a high threshold to go against a patient's previously stated pulse. But when you've got a family member who's distraught and unhappy and claiming that this was what dad would have wanted now and all that stuff, and you've got all this ascension, sometimes it's hard to hear through the noise. That's another reason that ethics can be helpful. Next slide. How does moral distress relate to ethics? There are all sorts of questions that can come up as you're in the middle of this situation. Primary question is autonomy. Is this what the patient would have wanted? Has the appropriate surrogate been consulted? Who's the appropriate surrogate here, right? We've got two. We've got questions of beneficence and non-maleficence. Is this really the kindest treatment for the patient? Is it causing undue harm? And in this case, the providers have said that it will cause more harm than good. And then the most basic ethical question, as I said before, do the burdens outweigh the benefits? And finally, questions of justice that can run through the mind of a person watching this. Although this rarely gets adjudicated with an individual case at bedside, there are cases where it does, but let's just say that this is more of an abstract, and yet it's real for the people who are on the front line. Is this the most appropriate use of scarce resources? Are there others who might benefit more from this resource? Going back to the question we asked a little while ago, is there someone else who needs this ICU bed, right? And what happens if we have a failed resuscitation or a semi-successful resuscitation effort and we bring the person back with very little, with anoxic brain injury, and then they stay in the ICU for a long period of time, right? Is this the most appropriate use of the resource? And as the nurse caring for that patient, it can be extremely distressing if it doesn't feel like the right thing to do. Next slide. So I'm just going to cue you up for a couple of self-reflective questions, and then I'm going to pass it along to Rebecca. How does moral distress show itself? You can experience distress in many different areas. Physical, you can't eat, you can't sleep. Emotional, you just feel like you're at the end of the rope all the time. Spiritually, this is really serious. I'm losing my sense of calling. I'm losing my sense of meaning in this job. Ethical, as I said a few minutes ago, and professional. Is this really what I want to continue doing? So that was the first part of the presentation, is my running through these slides describing moral distress and its effects. Now I'm going to turn it to Rebecca, who's going to talk about how do we respond to this new awareness.
Thank you so much, Jody. Good afternoon. So we're going to get really reflective really quickly. These next few slides are really about how we assess what's going on internally within us and try to separate what's going on externally. And then we'll discuss these things in a few more minutes. So one of my favorite authors, and I love this phrase because I've been thinking about it a lot and it's gotten me through a lot of hard days. There's an Irish author named John O'Donohue who writes, "A tree grows in two directions, up toward the light and down into the darkness." My hope is to offer resources and begin exploring the values deeply rooted in us and how they both inform our moral distress as well as serve as a resource in coping with moral distress. First of all, we take time to be intentionally curious. And I say curious because that combats that close-minded critical thinking and keeps us open both to ourselves and others. So consider the facts, the external facts and the internal facts. What's happening externally with the patient situation? And what has this awakened internally within you? For instance, the past 16 months have been extraordinary. With the pandemic, the sheer number of patient situations that disrupt our values are out of balance with the patient situations that affirm us. That disruption of balance is real, just like the impact of moral distress, moral residue, and moral crescendo are real. So consider how these situations impact our values and consider how the values deeply rooted in us help us to remain grounded. Let me be clear here. We all have core values. We may not be able to name them yet, but we all have core values and none of us fully live up to them. So they still remain our values and we need to be kind to ourselves as we consider them. So how do we explore our values and expectations with that kindness? Rummaging around in the darkness requires kindness because we don't know what we're going to find there. We just don't know what we're going to find there. That's why we always are so critical about the external, because it's so hard to look at the internal. So when we are able to be kind to ourselves in the midst even of these situations, then that kindness flows more naturally toward others who are also feeling the impact of this situation. So what do we hope for? What are our hopes and expectations? For instance, what are my hopes when I come to the hospital setting? First of all, I hope to find dignity and respect. I would imagine you have some things too to contribute to those thoughts, and we'll jot them down if you can, and we'll talk about them later. The second one is, what do we hope that we're going to get from and expect from medical ethics? Beneficence, do good. Non-maleficence, do no harm. Autonomy, justice, fairness. And I want to add that I also believe that the ethics team is where we can go to voice our concerns in a meaningful way. It is empowering to us, knowing that our voice is being heard, and it helps us remain close to our values. Okay. So how do others understand these principles and these values? What's the perspective of the patient or family member, for instance, or other people on our team? What is their understanding of these principles? Because we have our own hopes and expectations. What are theirs? And then what do we expect to find from ourselves? Boy, that's a hard one. What are we expecting from ourselves? Acknowledge those core values that have awakened your moral distress. Here's the thing. Remember the canopy of that tree we looked at the beginning? That beautiful green, lush foliage? It reflects how deeply rooted and grounded that tree is. Our moral distress really can reflect how deeply rooted and important those values are to us. Okay. So where and when did these values drop into our lives? That's what we're going to try to start to look at next, because they come up long, long ago in our origins. So the questions we're going to be talking about in a few minutes is, what is your origin story? When did you decide to be a nurse? When did you decide to be a nurse? If something came up for you right in the middle of that moment of me asking that question, jot down a word or two, because I want you to connect to that when we get to the discussion, because we're really going to take some time with that. Explore your story by yourself or with another really trusted friend. Explore your story with focus, intentionality, right? Focus, kindness, and presence to yourself. The biggest dignity and respect you can offer yourself is to make space, focused space to be present to yourself. In other words, know your distractions and get rid of them. This is going to be hard, so I'm not going to tell you to turn your phone upside down and leave the timer on. I'm going to invite you to turn your phone off. Liberate yourself from your distractions. Remove yourself from those noises that pull at you, and be with yourself as you explore these things. And then identify your values and identify them with understanding. What I mean by that is, don't make light of them. It's disempowering. Even if you're not sure what you're finding is exactly what you hoped for, explore it and begin to understand it, accept it, listen to it, because these values belong to you and they're deeply a part of what defines you. Gently consider how these values have been awakened and remain curious with yourself, and focus on how to connect to your values to sustain and guide you both in the moment, but also carrying you into the future. Moral distress, I like to say, feels like a collision. But what if it also brings with it some clarity? What if it also brings with it some clarity? I was part of an ICU case that all the caregivers were brought to their threshold. It wasn't an isolated issue that this case raised in everyone. And each caregiver began to speak very clearly. And as they spoke, they realized not only were they not alone, but their unified voice of moral distress and clearly stated values, both and, help the system also gain some clarity around, and change did eventually come. That doesn't always happen, but sometimes it does. All right. I almost said next slide, but I'm the one doing it. So intentionally connecting to our values. So how do we get started? In the moment, consider why, how, and with whom are you talking? And is it helpful? I am totally a fan of decompression sessions. Processing with our peers could be the first step to clarifying what's happening within us. But we all know when those decompression sessions turn negative. Don't get caught in the loop. I spoke with an RN recently who was telling me about their own decompression with peers and how they started to realize the negative turn it took and spiraled down, and they felt worse afterward than when they started. So they intentionally changed their practice. They did the hard thing, the thing that felt risky to them, and they went directly to the MD. And they went with intentionality with their distress and their values. It doesn't mean everything was suddenly changed, but it did help that RN stay connected to themselves and true to themselves. Their values were close to them, and they gained a sense of power and personal authority. And those are some of the symptoms that Jody talked about earlier. So finding and creating balance is another way. That nurse created and adopted a practice that was new to her. So I'm going to invite you to think about practices that connect to your values. I have a great book that I'm going to just show you really quickly. I think you can see it. And I talk about it later, but the author of this book, The Age of Overwhelm by Laura Vandernoot Lipsky, gives 2 quick examples. Now, I'm neither a nurse nor a judge, but both of these examples resonated with me, so I'm just going to share them with you. The first one is an RN who has adopted a practice of, I love this, she adopted the practice of just a gratitude practice, thanking each patient that she cared for, that she was assigned to care for one thing that patient did or said that contributed to the nurse's workday before she left. Simple, but meaningful, reconnected this person to their values. This judge gained the practice at the end of the workday to review each of the stack of case files they had made rulings on during the day, in hopes and with the goal of being able to find one ruling that made a clear and direct benefit to a child. That struck me because I have children, right? So be intentional. Adopt a practice. Be intentional about how you end your workday. Somebody said once, what are your bedtime stories? What are you telling yourself or watching on TV? Are they what you would want your child to hear at the end of the day? Is this what you would want to tell your best friend at the end of the day? I suggest you remind yourself, I am enough. I did all I could do today. I spoke truth when it was hard. I know myself maybe a little better tonight than I did this morning. I'm okay. I'm okay. So think about those things and take hold of those people and things that you have waiting at home. What holds you? Is it a purring critter or a wagging tail? Is it someone who gives you a hug but then doesn't let go right away? Are they silk pajamas or a great, amazing comforter? Savor those moments. Take time with them. As much time as you would take with the things that are causing moral distress, and connect with who you are. My other suggestion is that you protect your morning. Protect your morning. As soon as you wake up, you don't have to take 10 minutes or 30 minutes. Take 30 seconds and breathe and attend to yourself. This is who I am. Build an intentional practice into your day, an intentional kindness, letting somebody into your lane driving to work, buying the person behind you a tea or a treat or a cup of coffee. But know when you're doing it, know you can control it, and you acknowledge to yourself when it happens. That's something you did today, and it matches your values. All right. So I'm going to go back one more here. Sustainability and opportunity, I think we talked about. Is it sustainable? These are the hard questions we have to really start asking ourselves. Is it sustainable? I might have gotten ahead of myself here. Is it sustainable? That's the other question to ask yourself, and for how long? And what are our options moving forward? I know nurses that have left the ICU and they've gone into a private practice, they've gone down into a surgical unit, they just needed a break. I know others who their moral distress lit a fire under their values, and now they're part of a team that's helping to make some changes and address those things that really concerned them. And finally, consider what the choices you're going to make help you actually embody your values. You want them to embody your values. So resources for further engagement. There's two that are represented really strongly in my presentation, and I encourage you to invest some time individually exploring them and hopefully with someone, because I think other people help us see what we don't always see in ourselves. Okay, the first one is the American Association of Clinical Care Nurses. They have a framework for recognizing and addressing moral distress, and it addresses the 4 A's they came up with: ask, affirm, assess, and act. And I've put their website in there. The other one is the book I showed you earlier, The Age of Overwhelm with Strategies for the Long Haul by Laura Vandernoot Lipsky. She also speaks. I wish she'd come here and speak with us. I've been a little in touch with her. We'll see. Both of these resources, like I said, are represented in my presentation. Now, for the juicy stuff. If you're sticking around, we're going to get started right away. And for those of you who are not staying with us, I just want to thank you for being with us and for letting us join you as part of Healing Starts Here. We can stop recording and move into our discussion.
All right, I'm going to stop that recording right now.